So if you see, the heart of the system is the electronic medical records. Now what all it has all the prescriptions, all the reports, medical history of the patient, all the referrals that have been done, all certificates issued, and case history. So all that is there, that is the electronic medical records, and it can be connected to the central repository of the government. That APIs have to be written if it has to be connected over there. What we have integrated today is definitely a payment gateway, because doctors need payment for online consultation. There are other plans. So there is a payment gateway, there is a SMS gateway, so that all the appointments, prescriptions, other things, we are using SMS. We have video gateway. We are using Zoom for talking to patients who cannot come to clinic. It's or a follow-up case. We have integration with Zoom. Then we also have other APIs where we can talk to other softwares. So this is the heart. Then doctor, what all doctor can do, he can set up his clinic, his timings. They can set up multiple clinics, multiple fees. Then they can see the appointment. They themselves can set appointment. They have staff, they have paramedic staff. So staff can also manage appointments for doctors. They can look at EMR, they can write prescription, and they can see all the transactions in the system. Then we have pharmacy. So how pharmacy comes here is that the moment doctor completes prescription, if he has a pharmacy in the network, the list of medicines directly go to pharmacy if it is in the network. Let us say a case of a hospital pharmacy. The requisition can be seen by the pharmacy, medicines packaged and given to the patient, dispensed to the patient. They can also upload record of how many medicines have been actually dispensed. Second, we come to the diagnostic lab. So if doctor has advised any tests, any investigations, they will go automatically to the diagnostic lab if it is in the network. And they can view the details, they can upload reports. When diagnostic uploads report, immediately doctor can see, because it goes to patient's EMR. Then we have patient. Of course, in this system, we have given access to patient. But when it comes to DIISHA's project, patient may not have access. They can only see their prescription on WhatsApp or other SMS. Here, patient can book appointment. They can upload their past reports. They can upload their past prescriptions. And they can have in-clinic or video consultation. So this is the current scenario. We are already running this system, and we have a good amount of doctors who are there on the system. Now what we are proposing, after hearing all the discussions, I might be asking like from where all we can interface also. But here I think all flagged patients are going to come from CPPC, that is the Elsevier's software. The flagged patient, what we need is the Aabha ID. Once we have the Aabha ID, we can go to the Aabha repository site and collect details. Now, as we said that most of the data is masked, doctor does require the name of the patient because it has to appear on prescription. He requires the gender and age. These are the three mandatory things. So only these three information we will be pulling from the Aabha site. Then what we need more is, if you see any report which has been, how they were flagged, there was some indications. So we need to know what was the symptom, what was the indication at the past reports. So exactly from where to pull once the whole thing is set up, whether it will come from Elsevier or it will come from elsewhere, we have to see. But all the reports will come. The EMR will get updated. We also need ASHA's ID, the associated ASHA, so that any status update can be sent to ASHA if required. This ASHA will be linked to the patient. So one patient will have at least one ASHA ID who is taking care of the patient. Next, as you see, they can book appointment or straight away go to the nearest PHC. Here, when the doctor sees the patient is registered and there is it will automatically create an appointment if no appointment is booked, and a new incidence starts. One incidence is for one type of treatment. So if somebody is anemic, it is one incidence. The incidence starts and intimation can be sent to the health benefit disbursement site, whatever site is required. It can go there as a pre-authorization if required. Any intimation to be sent to ASHA, I was thinking ASHA will be having only one app, that is CPPC. We can send intimation to the CPPC software. Doctor will start consultation. They will write symptoms, diagnosis, medicines, examinations, any lab test, any instructions or advice, and follow-up date. All that is a standard format of ICMR which we have tried to follow. So prescription will be written, and as I said, automatically we have, with the PHC we definitely have pharmacy. So pharmacy will be intimated. They will dispense the medicine. They can also upload or write down how much medicine they have dispensed. So the prescription will remain open till all the medicines are dispensed. If complete medicines are dispensed, prescription will close. This is something we have to decide and see if we need it or not. But the system is there. Similarly, diagnostics lab, they will get a requisition. They will contact the patient, and somebody will go and maybe collect sample at the doorstep, or the patient may come to the lab. After testing, whatever report is there, once it is uploaded in the system, it can be seen by the doctor in the EMR. So there will be logins for pharmacy, there will be logins for diagnostics, and there will be login for doctor.
Is there any login for ASHA in this?
We have given it through patient.
So patient is logged in or patient is picked up from patient is logged in or patient is picked up from the flagged list?
Flagged list patient is picked up. The moment we register, we send an SMS with username and temporary password by SMS.
With a CC to ASHA who is attached to it.
I am not sending today, but we will send it once we have ASHA associated. Then, but do you want to permit ASHA to see patients login?
I don't have a wish list. Wish list has to come to you each and every step, but I'm glad that you have done a lot of work and you have came quite prepared. I'm looking at the development, I don't think so it will take much time for you to have a walkthrough. That walkthrough has to satisfy two people. One, the guideline which is given by ICMR to see a patient is an ethical ethics guideline. And second, state government, who is the health beneficiary disbursement system, how authorization is validated. If these two are happy, you're good to go. The rest all is in the practice already. And in telemedicine is not a new thing. It has now become 4-5 year old thing. And due to COVID, we have quite shifted to it. Very, anything else you want to add?
Yeah. Sorry. So once the treatment is completed, we will close the incidents. If the same patient comes with, let us say, some fracture in the hand or something, a new incidence has to be created, because the incidence has to be properly costed and a track has to be kept there. Something which I wanted to add here, this is just EMR, like everything is there regarding the patient, right from day 0. All prescriptions in chronological order, reports, referrals, case histories, certificates and all. Now we were talking about monetizing data. Two things are very important. One is that we follow disease code, ICD-10 or equivalent. What would ICMR suggest? Or do we have our own Indian standards? I would like to know that. Second thing I would like to know, that diagnostic code is also very important. Currently, we are trying to follow line code, try to implement 90%, not 100%. But yes, if there is a yes for this, then that is what we would like to go, so that it has meaningful, relationship and analysis can be done accordingly. And just drug code, I was thinking if we already have in India, if we want to follow a particular...
HSN code is coming. HSN.
Yes.
It's the international code and now it is implemented.
Which one? The
HSN.
HSNs. Okay. So if that is what we are following in India, that will be based on the generic medicine, the molecule. How is it? It is molecule based.
Overall,
Okay.
where from it's coming or it's manufacturing in India, then who's the manufacturer?
Okay.